Okay. Hello, Ms. Napo. Thank you for joining us. Good morning, David. How are you?
Good morning. How are you?
Well, thank you. Hello, Josie, over there. So I've been on the fence about whether we should do this in person, but I kind of have come to the realization I think it's easiest to see these tracings on your own screen. So I think EP probably benefits from this method. Okay. Here's Dr. Uzo. Had a very busy weekend.
Good morning, Dr. Pass.
Good morning, Uzo. Okay, we'll give it one more minute and then we'll get going. Good morning, Neha, Grace.
Good morning. Good morning.
Hope everybody had a nice weekend. Dr. Uzo and I had a lovely weekend. So.
Yes, Dr. Pass, a very lovely weekend indeed.
Yes. Okay, why don't we get going then? Today is the first day of the rest of your life. No, this is, we're going to do a review of arrhythmias. I give this talk every year. So for those of you who are already well experienced in arrhythmias, I apologize, but I feel it's useful for us all to start at one point, and then we can move forward throughout the rest of the year. So we're taking it back a step and gonna go through basics of arrhythmias. So can you all see the screen with Dr. Locke's face on it? You're seeing
Yes, we can.
Okay, great. Okay. So this is a quote from one of my mentors in cardiology, Dr. Locke, who wrote that the EKG is a useless test in pediatric cardiology, except maybe in diagnosing WPW. So I always like this quote because it's one of the rare moments when Jim was wrong. And so we're going to go over all kinds of aspects. This is basically an overview of electrophysiology, and starting next week, we'll go back to our usual routine, which we've been doing for the last year and a half that I've been here. Okay, so when we think about arrhythmias, there are the bradycardias, or the slower, sometimes people think of them as boring tachycardias or arrhythmias, and then the tachycardias, which are, of course, the more exciting ones. And there are really three forms of tachycardia, but clinically I like to think of them in two general baskets, specifically disorders of automaticity and disorders of reentry. And we'll go over each of those. So first thing to remember for everybody is the normal conduction system of the heart. So we all know that the sinus node sits at the junction of the SVC and the right atrium. And it's a structure that's actually surprisingly large. It can be as large as 16 to 20 millimeters in length. And basically, the impulse starts at the sinus node, conducts through various bundles through the atrium, ultimately reaching the AV node. And eventually, after the AV node, we have the bundle of His. Then the bundle of His separates into the left bundle and the right bundle down to the Purkinje fibers. And all of this is basically where all the action is in these basic structures. Now, Let's start with bradyarrhythmias or bradycardias. And the way I normally think about arrhythmias in the heart is I work my way from the top down. And I think about that when I'm doing assessment clinically of patients, because I find that if I use a similar approach in every arrhythmia, I don't forget anything. So working from our way from the top down, the first cause of of bradycardia are so-called sinus node dysfunction. And sinus node dysfunction is actually very rare in patients who have structurally normal hearts, but it is very commonly seen after palliative congenital heart disease and surgery. So in the acute stage, we see it not uncommonly in patients who've had AV canal repairs. I haven't actually ever seen this reported, but it's very common that AV canal patients need to be paced in the atrium, at least for the first day or two after surgery. Now, patients who've had a sinus venosus ASD repair not uncommonly have sinus node dysfunction afterwards and are slow. It's not hard to imagine since most of the action is in this area of the heart. And so surgeon is putting a lot of sutures and doing a lot of incisions around that area. More chronically, when we think about sinus node dysfunction, we remember that patients who've had the mustard or the Senning repair for transposition, something we don't see very often any longer, very commonly have sinus node dysfunction. And then more typically in the present era, patients following Fontans palliation for single ventricle also have sinus node dysfunction, and it's a very common problem. And, you know, for those of you who haven't seen a mustard done, probably very few have, in the mustard operation, as you know, the SVC and the IVC are baffled to the left ventricle, which is the subpulmonary chamber, and then the pulmonary veins are allowed to drain behind the baffle over to the right atrium and right ventricle, and which is the subaortic chamber. And as you would imagine, when you do this many suture lines, you know, it's literally hundreds of sutures here, it would not be shocking if a patient were to develop sinus node dysfunction. Just imagine how many sutures have to be done around the SVC when that happens. And although we don't see the mustard operation performed today very often, patients who have double switch operations, whether it is a mustard or a Senning, which is a variant on the mustard operation, do tend to develop sinus node dysfunction, and it isn't surprising when you see how complex a repair this is. And when we look here, just to see how common is it, this is a chart from Dr. Connie Hayes and Welton Gersony from Columbia over 30 years ago. And this is from the Journal of the American College of Cardiology. And this type of chart has been reproduced about 14 times already, just showing how people repeat the same study over and over again, but showing basically that on the y-axis are the percentage of patients in sinus rhythm, on the x-axis is time from surgery. As you can see that as we get out to about a decade out from the mustard operation, very few patients are still in sinus rhythm. And it's not shocking based on the operation. And this is an example of a patient who had a mustard operation. This is a case report from the early 90s when there were lots of these patients walking around, just showing what we would see, patients who would have just very long pauses. Here's a sinus beat followed by a pause, then a junctional escape beat, then a very long pause before there's a sinus beat again. And this type of Holter tracing would be very routine in patients after that. And similarly, Fontans patients also suffer from sinus node dysfunction on a similar degree. This is a table from a large study in 1998 showing that if you were 4 to 7 years out from a Fontans, nearly 50% of patients suffered from sinus node dysfunction. In fact, generally speaking, I would say that if you are more than, I'd say if you're more than 10 years out from a Fontans and your heart rate is above 100 in your patient, I would strongly recommend that you aggressively assess the EKG and be sure that the patient is actually in sinus rhythm. It is very rare, I would say, for a Fontans patient who's at rest to have a heart rate over about 90. And I have seen some very experienced, excellent cardiologists send patients from routine cardiology clinic home only to later discover that they actually had they were an atrial flutter and they had missed it. So always worthwhile when you see an older Fontan patient whose heart rate is above 80 or 90 beats per minute, you have to really scan the EKG and be very certain that the patient is not in some type of arrhythmia. It's interesting, this slide did not come, I redid this slide, but it's all right, doesn't matter. So after sinus node dysfunction, we think about conduction block. And so there are multiple, again, when I think about the heart, I start from the top in my mind's eye and I work my way down. So at the level of the sinus node, we've already talked about sinus node dysfunction, which sometimes people refer to as sinus node exit block, suggesting that there's something blocking the impulse from leaving the sinus node. One can have scars in the atrium, which can result in slowness in conduction from the A to V. Remember that there are these small little fibers that connect the atrium or the sinus node to the AV node. For example, you may have heard of Bachman's bundle. These can be disrupted when patients have heart surgery, and it can result in fairly long PR intervals sometimes. At the level of the crux of the heart, we hit the AV node, as we discussed a moment ago. And if there is, you can have, there are two forms of second degree heart block, so-called Mobitz 1 and Mobitz 2. In Mobitz 1 block, we generally see prolongation in the PR interval before there's a drop beat, and there's typically grouping of beats, which is a nice trick to tell if someone is in Mobitz 1. But generally speaking, in most cases, when you see Mobitz 1 on an electrocardiogram, it usually is due to AV nodal injury of some sort. Mobitz 2, what we see is P waves that just simply stop conducting. So a patient will have a normal or abnormal PR interval with no change in the PR interval, and then there'll be one or two non-conducted P waves. And generally speaking, we believe that Mobitz 2 block arises from the level of the His-Purkinje system below the level of the AV node. And this is obviously a higher degree of block. I should mention for completeness sake that there is a third form of heart block, which is 2-to-1, a second degree heart block, which is 2-to-1 block, where there's 2 P waves for every 1 QRS. 2-to-1 block could be either Mobitz 1 or Mobitz 2. There is no way to tell looking at the surface electrocardiogram definitively if the patient has Mobitz 1 or 2 when you see 2-to-1. It is, though, however, usually a form of one or the other, but the only way to tell that would be to put a catheter in the heart and see if there's a His signal before each QRS. And then finally, in third degree block, none of the beats conduct from atrium to ventricle, and there is the atrial and the ventricular rates are completely different usually and are unassociated with one another. Now, there are many causes of heart block, and I've listed many of them here. I think the most important thing to remember on this slide is that for children, the most common form of heart block is trauma due to heart surgery. So that is the one that we deal with mostly when we're taking care of patients who have congenital heart disease, and far and away, the most common cause of heart block is trauma. Following that, we have lots of other causes. So probably the second most common that we see in pediatrics are infectious causes of heart block. And, you know, viral myocarditis is a very common, oftentimes reversible cause of heart block in patients. Lyme disease can be a cause of heart block. Chagas disease, not seen so much in North America, but fairly common in South America. Diphtheria, which we don't see very much any longer because of immunization, but was a common form of a cause of heart block. And then, of course, if you develop endocarditis in the wrong part of your heart, you can develop heart block as well. In terms of inflammatory conditions, rheumatoid arthritis or Guillain-Barré can be associated with heart block. There are certain neurodegenerative disorders such as myotonic dystrophy, muscular dystrophy, and Kearns-Sayre syndrome, which are associated with block. There are infiltrative disorders like tuberous sclerosis, amyloidosis, lymphomas, sarcoidosis can potentially cause block. And then finally, there are pharmacologic reasons patients can have heart block. And probably the most common iatrogenic cause of heart block is digoxin. Digoxin overdose is a very well-known cause of heart block. In the old days, when we didn't have electronic medical records and the doctor would have to write the order, it was not uncommon that a patient would get an overdose of digoxin, usually a 10-fold overdose, and they would develop, high-grade AV block, sometimes complete heart block. I've seen that error made, unfortunately, many times, not so often in the present era. And then a lot of antiarrhythmic agents can cause heart block. A notorious one for that is amiodarone, which is given in the operating room. One of the things I often bemoan is when patients come back from the OR and the anesthesiologist has given amiodarone, but there are no wires, because not uncommonly it can cause transient AV node block, or at least slowing, which can make management postoperatively more challenging. By the way, if anyone needs to or would like to stop me at any time, of course, just unmute yourself and please do that. Okay, going forward. So this is an example. This is a 7-year-old who has a history of severe cold symptoms, lethargy, dyspnea. The echo showed severe ventricular dysfunction. And this is an example of a complete heart block. You see there are P waves at a rate that is faster than the QRS or ventricular rate, and there is no relationship. The R to R interval is relatively fixed, which we've discussed before in this conference. When you see a relatively fixed R to R interval, that is often a very good indirect sign of complete heart block when it's slow. And so this is an example of someone who has myocarditis and has heart block. And most of the time, heart block will resolve in myocarditis, but not 100% of the time. And so typically we'll support a patient, oftentimes either with isoprel or with temporary pacing, and then until conduction either resolves or does not. This, however, is a tracing from an 8-year-old who was referred to cardiology for evaluation of a heart murmur. We see here that the PR interval is lengthening from beat to beat until finally there is a drop beat. This is therefore Mobitz 1, or sometimes referred to as Wenckebach conduction. This is a normal finding, although not normal in an awake 8-year-old. This is a normal finding on a Holter monitor when someone is in deep sleep, often due to vagal tone, but it's somewhat unusual in an awake patient, and I would probably evaluate this if I saw a patient like this. So how do we treat bradyarrhythmias? Well, the most important one is to treat the underlying problem. And so if the patient has, myocarditis, or endocarditis, you would obviously treat with antibiotics, or depending on your religion, steroids or immunoglobulin. And if it didn't resolve, then the only treatment, of course, is to place a pacemaker. Now, if a patient has postoperative complete heart block, we typically will wait about 8 days after surgery in order to see if it will recover. Let me just ask David Barris if you could tell me, if a patient comes out of surgery in complete heart block, what's the likelihood that it will recover?
This is just kind of a ballpark guess, but what about 60%?
Actually, that's a pretty good guess. You should buy a lottery ticket, David. It's about 2/3 of the time conduction will recover. About 1/3 of the time it will not. And studies have shown, multiple studies, that 8 days is pretty much the line in the sand. By 8 days, roughly 97% of patients will have recovered. And that's the reason why most surgeons will wait. Some centers you'll hear 10 days, some places will be 1 week. Now, Dave, do you know why it is that let's say a patient has had open heart surgery and has a reasonable escape rate, why would we put a pacemaker in? In other words, if a patient, let's say, had a VSD repaired and is in complete heart block, is 10 days post-op and has a heart rate of 70, is very well perfused, feels well, looks well, why do we put a pacemaker in? Or in fact, do we need to put a pacemaker in definitively?
Just to maybe prevent the ventricular system from taking over, prevent ventricular arrhythmias.
Well, I'll give you full credit for that answer. The real reason is because patients who have a complete heart block following surgery actually are at a very high risk for sudden death. This study cannot be done today because we would not believe it is an ethical study. But in the early 1970s, when pacemaker implantation was very technically challenging, was riddled with multiple problems, you could still do a study where you compared patients after open heart surgery who did and did not receive pacemakers. And in fact, what they found was that there was about a 50% mortality at 1 year following surgery from Stokes-Adams attacks, which is essentially a bradycardia resulting in a ventricular arrhythmia, as you were suggesting. So the bottom line is, if a patient has postoperative heart block that exceeds 10 days, we would pretty much always put a pacemaker in that patient, and that's the main reason, even if they appear to be well. And there's various different ways. This is an example of a transvenous pacemaker implanted by my friend and colleague, Dr. Spotnitz over at Columbia, who's now retired from clinical practice. He used to put transvenous pacemakers in small children. This is actually frowned upon. We do not do this anymore. In fact, I think it would be fair to say that I am the reason that Dr. Spotnitz does not do this anymore, and no one does it, because the risk of occlusion of the subclavian and the cephalic and axillary vein is very, very high in patients who have transvenous leads at this low of an age. And also, Dr. Spotnitz, to his credit, studied his outcomes and discovered that there was a very high incidence of erosions when the device was put up here in small children. And so basically, his theory was that he could put enough lead in that with growth it would unfurl and patient could have a lead for very many decades. And you can see here, this is the same patient at 9 months and 30 months. But in truth, this is not a good idea. And in the vast majority of cases, we would epicardially pace a patient like this. So let's move on. So that's our general overview of bradyarrhythmias. So now let's talk about tachycardias. And again, when I look at and think of tachycardias, I, in my own mind, divide them into disorders of automaticity and disorders of reentry. Automatic arrhythmias are far less common than reentrant arrhythmias, but we need to know the difference between them. This is not just a theoretical consideration. And the reason we need to know the difference is because it has a very profound impact on how we manage and treat them acutely and chronically. So automatic arrhythmias are typically arrhythmias caused by the fact that there are calcium channels in the cell that are depolarizing spontaneously all the time. And for reasons that we don't understand, and I should just mention, take a step back, in the normal heart, the sinus node has the greatest degree of automaticity. And the second most automatic of tissues in the heart is the AV node. This is the reason why oftentimes in healthy patients, you'll see sinus rhythm, occasionally alternating with junctional or AV nodal hiss rhythm. But when patients have automatic arrhythmias, typically there is an area of cells either in the atrium or ventricle or in the AV node itself that are firing at rates faster than the sinus node. And so if that happens, then basically a patient will develop a tachycardia. So, and I think it's important to remember that one of the most important rules of the heart, which I'll probably review again, is that whatever is fastest wins. So normally the sinus node is the fastest, and so it is the rhythm that we are all in when we're in so-called normal rhythm. But when an area of myocardium is firing or activating at a rate faster than the sinus node, then we are in that rhythm. And so some of the common characteristics of automatic arrhythmias are that they heat up and cool down. So these are not the abrupt onset and offset type arrhythmias that we think of more with reentrant arrhythmias. Very importantly, these arrhythmias cannot be DC cardioverted. And in fact, the response to cardioversion could be considered to be a diagnostic clue as to the mechanism of tachycardia, which is one of the reasons why in a stable patient, if you're cardioverting someone, it's always a good idea to run the electrocardiogram paper while you're cardioverting, because the response to cardioversion is a very helpful tool. If a patient, for example, is in a reentrant arrhythmia and is cardioverted, and then goes back on the third beat after cardioversion, it might appear in real time as if the patient was never cardioverted, but in fact, if you look at the EKG, you can tell that there were a couple of beats that were in sinus before. And so the response to cardioversion is important because automatic arrhythmias generally cannot be DC cardioverted. And these arrhythmias are extremely catecholamine sensitive, and that is one of the important features of them that we take advantage of when we are treating these types of arrhythmias. So some of the clinical examples of automatic tachycardias are sinus tachycardia, which is our normal rhythm, ectopic atrial tachycardia, which we are increasingly seeing, particularly in post-op patients in the recent era, junctional ectopic tachycardia or JET, and then some forms of ventricular tachycardia are also automatic in nature. And again, as I mentioned earlier, it's very important to remember that whatever is fastest in the heart always wins. And so in an automatic arrhythmia, an area of myocardium with calcium channel cells are firing at a rate that's faster than the sinus node, and that is in fact the reason why we are in that rhythm. And this is an example of this. This is a 14-year-old girl, a tracing from a 14-year-old girl seen by a pediatrician who heard an irregular heartbeat, obtained an ECG, had a recent history of fainting without palpitations, and the echocardiogram showed severely depressed function. What we see here is an atrial rate that's fairly fast, over 150 beats per minute, maybe even 170. And what this is of course, ectopic atrial tachycardia. And in EAT, or ectopic atrial tachycardia, there's a focus of atrial ectopy from a single area of the atrium other than the sinus node that is firing very rapidly. And if one is chronically in this type of arrhythmia, you will have chronic ventricular dysfunction. And in fact, when heart failure specialists are doing animal experiments, one of the most common models for heart failure is to take an animal and to put a pacemaker in them and to pace the heart very rapidly. That will, within 24 hours, cause quite severe ventricular dysfunction and heart failure. And that is one of the more common animal models for heart failure. So EAT is obviously an important arrhythmia, which we see quite frequently. Another common automatic arrhythmia is JET. This is a tracing from a 5-month-old following tetralogy repair, post-op hour 4. And we see here in this second tracing, this is an esophageal lead, which is not unlike having an atrial lead. And we see that the ventricular rate, denoted by the little V level, Vs, is faster than the atrial rate. Normally, of course, the atrial and the ventricular rates are the same. And so when you have more Vs, and you can also see, by the way, that there is dissociation between the Vs and the As. The As are all over the place. When you have dissociation between the Vs and the As, and when you have more Vs than As, there's only 2 possibilities in terms of what this rhythm is. It's either JET or VT. And so that's a good little pearl. When there are more V's and A's and the V rate is fast, it's either JET or VT. And we'll go over how one would determine which of those 2 it is. But again, JET is usually not a type of arrhythmia that suddenly goes up. It's an arrhythmia that typically slowly occurs over time. And it's not uncommon, for example, for a patient to come back from the operating room after tetralogy repair in sinus rhythm and to develop junctional ectopic tachycardia over the first period of time. This is an example of a 15-year-old who had a history of ventricular tachycardia and was non-compliant with her medication. And you see on the left-hand side, the patient is in a wide complex tachycardia. I apologize for the somewhat crappy tracing. And I asked the patient to lift their legs. In other words, I wanted them to exercise. And my goal was to try and transiently increase the sinus rate by increasing adrenergic tone. And as you can see, when she started to exercise and doing some abdominal leg lifts, you see that she went into sinus rhythm, that the ventricular rhythm terminated transiently. And this is a nice example of whatever is fastest in the heart wins. So I raised the sinus rate temporarily by having the patient exercise. The VT was suppressed by that. And as soon as the patient put their legs down, within about 20 seconds, they were back in VT. And we ultimately just decided to ablate this patient because of concerns of noncompliance. Okay, let's move on to reentry, which is the most common form of tachycardia seen in young people. It represents 90% of SVT in pediatric populations. And when we think about reentry, you always have to remember that there needs to be three major requirements in order to have reentry. The first is that there needs to be two pathways that are connected proximally and distally, as in this little diagram. There needs to be unidirectional block in one pathway. Now, why is that? The reason is because if you're here, let's assume this is the atrium on the top, and this is the ventricle on the bottom. If you're going from A to V through these two pathways, there would be no way to reenter if they both conducted antegrade. I'm wondering if somebody has, it sounds like they're putting the garbage out in the back. Let me see if I can mute everybody. I don't seem to know how to do that, but if you can just mute yourself, that'd be helpful. Thank you. So when we're conducting through both pathways, you can't reenter, because if you conduct down both pathways simultaneously, they will both be, depolarized and therefore not ready for any further electrical impulse. So when the signal goes down one, they cannot go up the other because they're basically refractory. So you need to have not only two pathways, but there needs to be unidirectional block in one of them, which would allow reentry. Finally, there needs to be a zone of slow conduction. And the reason you need to have a zone of slow conduction is because by the time the impulse comes down, if it's going to reenter, if it reentered very rapidly, if, for example, there was no slow conduction and the impulse just went down one limb and then went back up the other limb, then basically reentry would occur, but the atrium would not be able to receive the impulse. It would be refractory from the prior sinus beat. So there needs to be enough slowing so that by the time the impulse comes back around, the atrium actually is not refractory so that the reentry can continue. So again, you need to have two pathways connected proximally and distally. There needs to be unidirectional block in one pathway, at least temporarily. And finally, there needs to be a zone of slow conduction to allow the reentry to actually occur. Let's move on. So what are some of the general characteristics of reentry? Well, this is a rhythm that can be initiated and terminated with appropriately timed premature beats. It has typically a very important feature is that it has abrupt onset and termination. And this is why looking at heart rate trends on a monitor in the ICU is always a great idea. And then finally, and importantly, reentrant arrhythmias can be terminated, at least temporarily, with DC cardioversion. And this, again, is a very important, at least diagnostic feature of them in order to help make this diagnosis in real time. So what are some of the more common examples of reentry? Accessory pathway mediated tachycardia or bypass tract tachycardia is the most common that we see, and the most classic example of that is Wolff-Parkinson-White syndrome. AV nodal reentry or AVNRT is another common form of reentrant SVT we see in children. Atrial flutter is another reentrant arrhythmia. And then finally, just like there are automatic ventricular arrhythmias, there are also some forms of ventricular tachycardias that are reentrant as well. So when we look at tachycardia that are reentrant, the most common for sure in pediatrics is accessory pathway mediated tachycardia. It is somewhat more common in males, so in almost every ablation paper, you're always going to see that males predominate a little bit. It's like 60-40 males to female. And the typical route is from the atrium to the ventricle via the AV node, and then from the ventricle to the atrium via the accessory pathway. And when you go down the AV node and then back up the accessory pathway, we will often refer to this in the electrophysiologic world as orthodromic reentrant tachycardia, or ORT. And as I often joke to cardiology fellows, particularly when they start out, starting immediately at this moment, it is presently 7:34 a.m. Eastern Standard Time. You're no longer allowed to use the word SVT. We're going to get a little more precise in our description of what the mechanism of tachycardia is. So ORT, or tachycardia mediated by an accessory pathway, which is sometimes also referred to as AVRT, or atrioventricular reentrant tachycardia, is the most common form of SVT in kids. And this is an example of a patient who has who's 15 and has Epstein's anomaly and intermittent palpitations. And you all remember that Epstein's patients very commonly have accessory pathways, something like 50% of them do. On the right-hand side of the screen, we see the patients in sinus rhythm waves, small QRS, very typical for Epstein's to have right atrial enlargement. And then on the left-hand side, we see the patient in tachycardia. And in tachycardia, what's notable is if you look at the period between the QRSs, we see these what appear to be gigantic T waves. But when we look in sinus rhythm, we don't see those gigantic T waves. And so what this is, in fact, are P waves that are superimposed on the T waves. So these are what we would refer to as retrograde P waves. And we notice also that the R to P interval is very long. And generally speaking, we would say that if the R to P interval exceeds 70 milliseconds, then that is very typical of orthodromic reentrant tachycardia in comparison to the second most common form of SVT, or reentrant arrhythmia, which is AVNRT, in which the RP interval is less than 70 milliseconds. So this is obviously substantially more than 70 milliseconds. So this is some kind of an accessory pathway mediated tachycardia or orthodromic reentry. The peak age of occurrence for SVT or ORT is the first 2 months of age. 40% of first episodes occur this early in life. So anybody who's worked in NICU has taken care of patients who've had orthodromic reentry, very common. And the frequency will decrease over the first year of life. And by a year of age, roughly 2/3 of infants will no longer have clinical tachycardia. And by that, I mean never in their life again. Now, if you have WPW as an infant, some more recent data suggests that it's more like 50%, but the bottom line is there's at least a 50 to 63% chance that if you have SVT in the newborn period, and by that I mean ORT or AVNRT, that you will no longer have it ever again after a year of age. And this is one of the most important reasons that we are not rushing to the cath lab to ablate small infants, because we are hoping that the natural history will be favorable in most patients. If you actually formally test these patients, it turns out that 1/3 of patients will have no evidence for accessory pathway conduction at all if you do formal transesophageal testing. And the 1/3 that do, that are not having tachycardia, will also never have tachycardia again. So presumably those pathways also eventually stop conducting. So the bottom line is the prognosis of a young infant who has SVT or ORT is quite favorable. And that is the reason why we would typically medically manage these patients for the first year of life in the hope that it will resolve on its own. When the other peaks of tachycardia recurrence are 5 to 8 years of age, and then again in the teenage years, which is reflected in our ablations, where we are mostly doing teenagers. And so again, about 35 to 40% of patients with tachycardia as young infants will recur. So which is why I always tell parents of children with tachycardia, infants, that when I discharge them from clinic at 2 or 3 years of age, I say, don't lose my card, because there's a reasonable chance they might need us still in the future. Now, I wanted to briefly talk about WPW, which is the paradigm of ORT. It was first described in the present way we understand it in 1930, although there are descriptions of Wolff-Parkinson-White syndrome by other investigators as early as the late 1800s. It's characterized by a short PR interval, the appearance of what is a bundle branch block on a resting surface electrocardiogram and intermittent tachycardia, and there is in fact a so-called delta wave or ventricular preexcitation. So in this little cartoon, if this is the sinus node, the impulse goes across the atrium and it goes down the AV node just like any impulse would, but because there is an accessory pathway, part of the ventricle is being depolarized through the accessory pathway as well. And this part of the ventricle would not normally be depolarized earlier than the AV node and the area near the crux of the heart. Therefore, this part of the ventricle could be said to be pre-excited or excited earlier than it ought to be normally, hence the term pre-excitation, and this causes a widened QRS as well as the delta wave with a short PR interval. And importantly, the risk of sudden death is estimated roughly in the range of about 1 to 1.5 per 1,000 patient years. So this is an example of a 15-year-old boy with an insignificant past medical history who's seen in the emergency room with palpitations and dizziness. And what we see here is a wide QRS tachycardia, which is very fast. Some of the R to R intervals exceed 300 beats per minute, and it is irregular. And it is irregularly irregular. And so the patient received defibrillation for this. And this is the rhythm that was seen afterwards. And as you can see, the patient has WPW and is pre-excited. And so what was that arrhythmia? That was so-called pre-excited atrial fibrillation. So the reason that patients die when they rarely do with WPW is not because of ORT, which is of course the most common arrhythmia that we see. Rather, it's from pre-excited atrial fibrillation. So patients with WPW, for reasons that are not well understood, have a higher than normal incidence of atrial fibrillation. Now, if you don't have an accessory pathway, your AV node will not conduct at rates that exceed much above 200 beats per minute. And so even if your atrium is going at 400 beats per minute in AFib, the ventricle will not. However, if you have WPW, and if your WPW accessory pathway can conduct at rates that exceed the AV node rates, and in most studies, it's been shown that if it exceeds 250 beats per minute or can conduct that rapidly, what was atrial fibrillation can become ventricular fibrillation, which is, of course, life-threatening. And so it is this combination of AFib, WPW, and importantly, an accessory pathway that can conduct rapidly that is the cause of the rare incidence of sudden cardiac death in Wolff-Parkinson-White syndrome. And so the key points for WPW are that the risk of death is not from SVT or ORT, but is instead from rapidly conducted AFib, which I will mention is very rare in infants. The use of digoxin and verapamil are contraindicated in older patients or younger patients with WPW, and that's because both agents have been demonstrated to potentially enhance accessory pathway conduction. And then finally, it's very important to educate parents about the signs and symptoms of tachycardia, particularly in infants, because if you're stuck in ORT for longer than about 12 to 24 hours, heart failure can develop. Now, this is an example of a 16-year-old with palpitations and dizziness, 10 years following a Fontans for tricuspid atresia. And what this is in fact, this is kind of a lousy tracing, but the heart rate in this tracing is about 110, the ventricular rate. And what this is actually, if you recall earlier in this conversation, I explained that anytime you see a Fontans patient with a rate over about 80 or 90, you should be very suspicious for intra-atrial reentry. And in fact, this is a patient who is in intra-atrial reentrant tachycardia, which is the term that we use to describe patients who have tachycardia of atrial flutter in congenital heart patients. It's a very common problem affecting, I wrote here 12.5 to 26% of patients with palliated congenital heart disease. That's probably about true. But with patients who have complex heart disease with multiple operations, such as Fontans patients, it's quite common. And in fact, this chart, this creepy old chart, is from a paper by Steve Fischberger from way back in 1997. But there have been multiple studies that have repeated this, showing almost a virtually identical Kaplan-Meier type chart. On the y-axis is time from the Fontans operation. On the x-axis is freedom from atrial flutter. And you see that by 20 years out, virtually nobody after the Fontans was spared atrial flutter. And, you know, one of the reasons that we advocate in the present era for extracardiac Fontans is the theoretical reason that will be less incisions in the atrium and perhaps they will be at lower risk for atrial flutter. As you can see, you really need time following surgery to develop this arrhythmia. This is one of these problems where the incidence grows over time. And so because extracardiac Fontans are relatively new, I would say it's fair to say that the jury is still out as to whether or not that will prove to be actually true, that the incidence of arrhythmia is lower in that type of Fontans. We'll see. And when patients have intraatrial reentry, there's typically a reentrant loop due to scarring. So if you imagine that this is a scar, just like any reentry, you have two pathways. In this case, the pathway on either side of the scar. There is unidirectional block, usually because there's differences in refractory period. And finally, there's a zone of slow conduction, which allows reentry to occur. And identifying these scars and where the slow zone is important when we're thinking about ablation. So just to summarize what we've reviewed this morning in terms of tachycardia, again, when I think about the heart, I think about arrhythmias, in my own mind's eye, divide them into automatic and reentrant arrhythmias, and then I work my way down the heart in my thinking as I'm looking at an electrocardiogram. So at the level of the sinus node, the most common automatic arrhythmia is sinus tachycardia. And there is actually a rare form of reentrant tachycardia called sinus node reentry. At the level of the atrial muscle, the automatic arrhythmia that we've discussed this morning is ectopic atrial tachycardia. There's also another automatic arrhythmia called multifocal atrial tachycardia, sometimes also referred to in pediatrics as chaotic atrial rhythm. They are the same thing. And then we've just talked about intraatrial reentry or atrial flutter and atrial fibrillation, both reentrant atrial muscle arrhythmias. At the level of the AV node and His-Purkinje system, when we think about automatic arrhythmias that afflict that area, we think about JET or junctional ectopic tachycardia, which is enhanced automaticity of the His bundles. In fact, in Europe, it's not uncommon to refer to JET as a His bundle tachycardia. And then the reentrant arrhythmia affecting the crux of the heart is the AV-NRT or AV nodal reentrant tachycardia. When we think about AV reciprocating tachycardias, there is no such thing in the automatic category, but WPW, or patients with concealed pathways, are the classic examples of reentry. And then finally, at the level of the ventricles, VT can be either automatic or reentrant. And one has to do an EP study or at least observe a lot of electrocardiograms in order to distinguish the mechanism between the two. So that's my quick and dirty overview of all of arrhythmias, so that we're all starting at the same point. I think we'll stop here because we have our Sinai conference in just a few minutes. Are there any questions before we end this meeting today?
I have one quick question.
Sure.
We're talking about for reentry, you were saying there was the 3 requirements. One of them was the unidirectional block.
Yes.
But just one thing I'm a little confused about is with Wolff, Parkinson, White, you are, in orthodromic, you're going down the, the AV node, but then you're also pre-exciting as well to the ventricle via the accessory pathway.
Right. That's an excellent question, David. So in ORT, you're going down the node and going through the pathway retrograde, right? So you're asking if it can conduct antegrade, how does that work? Well, remember, so how do we have reentry in a WPW patient? Well, first of all, you have the two pathways. In this case, the two pathways are the AV node and the accessory pathway. But as you rightly point out, if you're in sinus rhythm and you can go down the AV node and the accessory pathway at the same time. And in fact, that's why people are quote unquote pre-excited, because they're going down both. So the question then is, how is it that they can have ORT if you can go down both? And the answer is that in order to have ORT in a WPW patient, you need to have a premature atrial contraction. And that PAC has to fall at exactly the right moment that it takes advantage of the differences in the effective refractory period of the pathway and the AV node. So if you put in a PAC and you block in the pathway because it is too premature, but if your AV node can conduct antegrade at that cycle length or at that degree of prematurity, then that is what causes transient unidirectional block in the pathway. So in patients with WPW, just like any other reentry, there needs to be unidirectional block. And the unidirectional block is achieved by a premature beat that falls at exactly what is often referred to as the tachycardia zone, which is that little window in the difference in the ERP between the AV node and the accessory pathway. So you go down the AV node, but you cannot antegrade go down the pathway because the APC is too premature for the pathway. And then it slows in the AV node because there is decremental conduction in the AV node. And if there's enough slowing, then when it goes down to the ventricle and tries to go up the pathway, if the pathway is no longer refractory from that PAC, reentry can occur. And this is, in fact, the reason why people with WPW are not in tachycardia all the time, because it's not just any PAC that can put them in, and sinus rhythm doesn't put them in. It has to be a PAC that is just early enough to block in the pathway, but to go down the AV node. And that's the reason why WPW patients, even though they conduct antegrade, can in fact have ORT. So that's actually a very good question. All right, so I think at this point we're going to stop. I want to thank everybody for joining this morning.